that, we need to check in with the patient after each position change by asking them, is the pain better, worse, the same, or gone? And the gone is very important, because if the pain is completely gone, once a particular position is reached, then that's the final position for the treatment. And that's where you remain for the 90 seconds of treatment duration, longer if the patient continues to experience a benefit or a reduction in their pain. So that's kind of the overall layout. Again, checking in with the patient after each position change is critical. And then once you've found your best position, either after a series of, say, 5, 6, 7 position changes, you're not getting any more improvement, then the best position you found so far is the one you'll stick with. Or if you found a position that completely relieves the pain, then of course that's the position you would use. So anyway, once you've spent your 90 seconds in that position, then maintaining your palpation over that same tender point the way that you have been throughout the technique, you return the patient to neutral, check in once more with them. What is their pain rating for that tender point on the same 1 to 10 scale or 0 to 10 scale? And then they can give you an impression of what change has occurred as a result of the treatment, and you can make your decision about whether or not to repeat the treatment, do a different treatment, or wrap it up for that day. So that's kind of the basic overview for strain counterstrain. And again, we're looking to enact position changes that shorten the muscle, creating a hollow space around your palpating contact, typically a thumb, for the anterior musculature, or one of your fingertips for the posterior cervical musculature. So again, any position change is fair game as long as it's relieving the patient's pain. So we start with ones that shorten the muscle, but if that's making things worse, then we're open enough to try the other positions, basically looking for any positions of relief. So start with shortening positions, but move into any directions that create relief for your patient. So any other questions about strain counterstrain? Okay. Without any stigma or judgment whatsoever, does anyone feel that that's necessary to practice? Okay, great. So let's move on, and now we can talk about our PIR procedures. So more contract relax procedures. These are now muscle specific as opposed to the METs, which are joint restriction specific. So we're thinking about directions rather than individual muscles. So from here, if I can have a volunteer to lie face up, we'll start by looking at PIR for the scalene muscles. Great, thank you. Okay, so 2 positioning steps will be common to all of our scalene PIRs, and that's going to be lateral flexion away from the involved side and extension. Now, those 2 movements will vary in their amount required to reach the first barrier, but those 2 movements will always be present as part of your setup for scalene PIR. So you can kind of fall back on that. You always know what your first 2 positioning movements are. You need to laterally flex away from the involved side, and you need to think about the degree of extension you want to induce into the neck. So knowing that, let's look first at the anterior scalene muscle. This is going to add to those contralateral lateral flexion and extension. We're also going to add ipsilateral rotation, or rotation towards the affected side. So let's look at now doing PIR for a right anterior scalene. And again, our goal here is to reduce hypertonicity or shortening in a muscle. And so for that, we're going to find the first barrier of stretch, not the biggest stretch that we can place on this muscle, but just the first resistance that we feel. So this is a relatively gentle technique. We're not looking to aggressively try and lengthen a muscle mechanically, because we really know that that's not the best approach. That's going to produce more trouble than it solves. So from here, we begin with our 2 steps that we know we need to include: lateral flexion away and extension. So a good way to work with our extension is to support under the patient's skull using our free hand to move the headpiece. Good. So for the anterior scalene, and you might imagine as we kind of trace the course of this muscle, more extension is actually going to assist in bringing the stretch to that muscle. So we'll use more extension than for our other scalene PIR positions, as well as rotation towards that affected side. So here, we have a good first barrier of stretch. The patient can now be instructed to bring their neck into a neutral position or try and straighten their neck. You can also say, push into my resistance, and you can give them pressure with, in this case, your right hand in order to get their contraction appropriate. So from here, they're instructed to contract at 20% of the effort they can generate while looking up and breathing in. And then after 10 seconds of this, they can be instructed to look down, breathe out, relax the muscle. And from here, we slowly, after waiting for that muscle to relax, 1 or 2 seconds, then we slowly find the next barrier of stretch. So we can do a little more lateral flexion away, we can do a little more rotation towards, we can do a little more extension if necessary. So any of these movements are okay. We can combine them in order to find that next barrier of stretch. And it's critical to have access to all of these three movements because different patients' bodies will move somewhat differently and will respond better to certain directions in order to create that stretch. So anterior scalene. And we'll just go through the scalenes and then practice and then move on. So anterior scalene that way. Middle scalene involves no rotation. So we're looking here just at lateral flexion away plus extension. So again, supporting under the patient's skull, now moving with our free hand at the headpiece. We have lateral flexion and extension. Once we found that first barrier, same procedure. You can either have the patient push into your hand or attempt to straighten their head and neck. Either way, 10 seconds, 20% effort, looking up while breathing in, and then after those 10 seconds, looking down, breathing out, again, waiting the critical 1 to 2 seconds for the muscle to let go, and then finding that next barrier of stretch by increasing those same movements that we worked with. So middle scalene, no rotation. Finally, for posterior scalene, we're going to have those same two initial components, lateral flexion away plus extension, and for posterior scalene, we'll need relatively less extension. Now from here, we're going to add rotation contralaterally, or away from the affected side. So now we have our three components to this positioning, and we can have our patient do their same process of resisting the pressure of our hand or trying to straighten their head and neck while looking up, breathing in, 20% resistance for 10 seconds. And then after 10 seconds, relaxing, eyes down, breath out. 1 to 2 seconds to let the muscle let go, and then we'll find our new position by adding to any of those three movements. More likely, rotation and lateral flexion will serve you here rather than extension. So extension is relatively less important in the posterior scalene, but as long as you can bring that muscle into a position of greater stretch, that's really what counts. So knowing the directions is definitely helpful and necessary, especially at the beginning. But in time, that's really less important. So with a little practice, you'll just feel how to get the muscle into a position of greater stretch. And that's really the key to this technique. So questions on scalene PIR? Okay, let's practice this on one another.